All right, the first step in blood clotting is called primary hemostasis, and this consists of the platelet plug. Later down the road, the next step will be secondary hemostasis, which has to do with the coagulation clotting factors. And again, platelets has more to do with these superficial cuts and the bleeding time, while the coagulation factors has to do with the deeper joint bleeds. So we get a break, and our first line of defense is these platelets, which will basically seal off the area, and they'll accumulate, and then we can even see this purple stuff in here that's layered on top is the fibrin mesh, the secondary hemostasis. So how does all of this work? Platelets are small fragmented cells from really just exploded or degranulated megakaryocytes. So in the same way that EPO, erythropoietin, causes red blood cell production, thrombopoietin from the liver helps regulate platelet production. Platelets are normally active, just floating through the blood, but they are activated by the subendothelial layer. This would be indicative of an injury. Obviously, the endothelial layer should usually seal off the vessels, so you would only have access if there's trauma. They can be activated initially by this, but then once platelets become activated, they start to activate other platelets in a positive feedback mechanism. There are 3 steps overall to the activation of a platelet plug. One is adhesion. So 2 and 3, these kind of happen more or less at the same time, but they're going to secrete various signaling molecules which will initiate positive feedback, activating platelets, which activate platelets, which activate platelets, and then they will bind together the aggregation. So they will adhere, they will secrete things, and then they will aggregate, happening more or less at the same time. Von Willebrand factor, this is going to be an important molecule both for platelets and the coagulation factors. This is made by endothelial cells and stored in Weibel Pilates bodies. So we saw this with neutrophil migration. This is where the rolling came into play with P-selectins, but this also now stores von Willebrand factor. It's also made by megakaryocytes, which make platelets, so it's going to be stored in alpha granules and platelets. So von Willebrand factor is both in Weibel Pilates bodies, also in alpha granules, and they're going to degranulate upon vascular injury, spilling this von Willebrand factor into the vessels. Von Willebrand factor binds factor VIII. More on this later, but it also binds to platelets, to the damaged endothelium. This is effectively the adhesion process. Later down the road, we'll also see it play a role in platelet aggregation. So it does a lot of different things. It's a really important player in hematology. So a couple proteins that are important for platelet activation: GP1, GP2, and GP3. All of this is more or less chronological. So starting with GP1, so here's our endothelial cells. If we have a break shown here, the subendothelial layer, the platelets will be able to bind to the von Willebrand factor here, adhering them to the damaged site. Again, this is just a zoomed-in version, the platelets binding to the von Willebrand factor at GP1. So then the next step, again, kind of at the same time as secretion, is the aggregation. So GP2 and GP3. So there's something called inside-out signaling. So we always have these GP2 and GP3 proteins, but they're effectively turned off. But various signaling molecules can basically, through gene expression, we can signal outwards to these proteins, activating them, exposing them so that they can bind to other GP2, GP3, causing a clumping effect. So this would be an inactive platelet. Notice it still has its GP2 and GP3. They just haven't been activated. Things like ADP, thromboxane, and thrombin will activate them. Now, they don't necessarily bind directly to one another, but using fibrinogen as a mediator, they can bind each to fibrinogen, which will bind them to one another. Sometimes, though, they can use von Willebrand factor to also bind to one another, but usually it's going to be fibrinogen. So just to recap at least the role of von Willebrand factor in platelet activation, the subendothelial layer, so here's my endothelium, so this would be sub. Von Willebrand factor will bind to GP1, and then that is the adhesion component, but then the aggregation component is that von Willebrand factor or fibrinogen, usually fibrinogen, will be the factor which binds the GP2 and GP3 from one platelet to another platelet. So the secretion component, yes, platelets are activated by the subendothelial collagen and the von Willebrand factor, but I would say that the brunt of the activation is gone ahead and triggered by various secreted substances, usually from other platelets themselves. And so this is just classic positive feedback. Platelets are secreting substance, which are activating other platelets, which will then secrete more substances. There's two granules inside of platelets. We have dense granules and alpha granules. So the alpha granules, I'll always think of like alpha, like an alpha male, somebody being large. These are going to have the larger biomolecules like fibrinogen, von Willebrand factor, platelet factor 4, all of these large proteins. Platelet factor 4, this is important. This is something that complexes with heparin, which we'll talk more about later. So heparin is a drug, and heparin combined with platelet factor 4 can precipitate an autoimmune reaction. This is called heparin-induced thrombocytopenia. Effectively, we're going to activate all of our platelets at once and cause a thrombocytopenia. It just means that we have a low platelet count now. Then looking at the dense granules, these are going to store, something's dense, it's going to be relatively small. And so the smaller things like ADP, calcium, and serotonin. ADP is released by damaged red blood cells, so it would make sense that this should activate. If you have damaged red blood cells, that's a sign that you probably have trauma, which means you probably want your platelets to be active. So these will bind to P2Y receptors, which are G protein coupled receptor inhibitors. And if you recall, a G protein coupled receptor typically activates adenylate cyclase, but if it's a GPCRI, it's going to inhibit. And if it's going to inhibit, this means that we are going to lower the levels of CAMP. So low levels of CAMP are going to then cause calcium release, degranulation, and shape change, which allows for aggregation to take place. This is the inside-out signaling that we were just talking about. So another use of serotonin is that when we have this heparin-induced thrombocytopenia, shown on this next slide. So platelet factor 4 complexes with heparin. You have autoantibodies which will bind to this and then cause all of these platelets to activate, aggregating to one another. We see that one of the things that's released from the dense granules is serotonin. So to test to see whether or not heparin-induced thrombocytopenia is taking place, we can go ahead and put radioactive serotonin in. And if we detect the radioactivity of the serotonin being released, that tells us that we in fact have a hit pathology. Another thing that activates these platelets is thromboxane. So in addition to ADP release from dying red blood cells, they will also release some arachidonic acid from their membrane. So the membrane phospholipids turn into arachidonic acid with phospholipase A2. Cyclooxygenase, COX enzymes in the platelets can then turn this into thromboxane, and then the thromboxane will activate them. And we'll talk more about this later, but aspirin is it's commonly called a blood thinner. Aspirin, on the one hand, inhibits COX so that we don't get the prostaglandins, and this reduces inflammation, but it also reduces the thromboxane, which is necessarily for platelet activation, hence the anti-clotting effects of it. This is just a good summary. So here we have our platelet. It binds to the von Willebrand factor. Once we have here's our endothelial cell. So this is an exposed area. It binds to the GP1 receptor. Remember that things are chronological. That causes the platelet to adhere. A dying red blood cell might release a bunch of ADP, which can bind to the receptor. This will lower the CAMP levels, which causes degranulation of the dense granules, of the alpha granules. Similarly, red blood cells can release arachidonic acid, which through cyclooxygenase we can turn into thromboxane. That's also going to activate these things. This causes the inside-out signaling, which causes the GP2 and GP3 to turn into their active state. They don't bind directly with one another, but they will bind either through fibrinogen or von Willebrand factor, and this causes platelets to stack on platelets, which is just going to quickly seal up our vascular tree.